Hi everyone, my presentation is on assessing suicide risks using evidence-based strategies. Here are some terms you should know. Non-suicidal self-injury, which is when you harm yourself without suicidal intent. Suicidal ideation, which ranges from passive death wishes to active thoughts of committing suicide to having a specific detailed suicidal plan with intention to carry it out. Suicide attempts, which is when you actually intend to end your life but do not die, and suicidal behavior, which are self-injurious acts with the intent of ending one's life. So, what are the suicide rates? Suicide is the second leading cause of death between 15 to 34-year-olds. It's the 10th leading cause of death for all ages, and over the last decade, suicide rates have increased by 62% from 2009 to 2018, tripling in the age range between 12 to 18. And for every death, there are an estimated 25 additional suicide attempts. Now let's get into the evidence-based strategies. So, educating general practitioners and non-psychiatrist physicians lowered suicide rates, non-fatal suicide attempts, and suicidal ideation. This also may prevent more suicides than further training for psychiatrists. So general practitioners would include doctors and nurses who see 45% of future suicide patients in 30 days prior to suicide and 77% within 12 months of suicide. Also, educating the youth resulted in less suicidal behavior and less ideation. System-level education, which is a combination of education, training, and screening, was also found to lower suicide risk. So the key factor in this is the population that is targeted. In a study, it was found that targeting high school students was found to prevent suicide attempts, but targeting high school teachers did not find much of a benefit. Screening for suicide risks is important in identifying undetected at-risk individuals. So these are some screening tools. The P4, which assesses past suicide attempt, suicide plan, probability of completing suicide, and preventive factors. The Columbia Suicide Severity Rating Scale assesses severity of previous and current suicidal behavior, suicidal ideation, and preparatory behaviors such as non-suicidal self-injury. The Suicide Assessment 5-step evaluation and triage guides clinicians to identify risk and protective factors, inquire into suicidal thoughts, plans, behavior, and intent, determine risk level, and choose an appropriate intervention. There's a lot of other screening tools out there, but these are the main ones that I read about. And these are some treatment interventions. So psychotherapy, which includes CBT, cognitive behavioral therapy, was designed to help high-risk individuals apply more effective coping strategies in the context of stressors and problems that trigger suicidal behavior. So this decreases suicidal behavior risk in adults and adolescents with depression and BPD. It may work by improving negative problem orientation and emotion regulation, reducing impulsiveness, and lessen suicidal ideation. DBT, which is dialectical behavior therapy, was also mentioned to prevent suicide, but it was shown that a treatment dose may be a factor because a single session of DBT was not found to reduce suicidal ideation. Group psychotherapy also reduced suicidal ideation in 5 of 10 studies and suicide in 1. Follow-up contact intervention. So most individuals are at greatest risk of suicidal behavior after discharge from the hospital. So follow-up contact has been found in reducing these behaviors. For example, sending postcards, calls, or in-person contact. Collaborative care involves inserting psychiatric expertise within a primary care setting, Army unit, and schools to enhance mental health care. This benefits suicidal ideation but did not prevent suicidal behavior. Internet-based interventions was not shown to prevent suicidal behavior, but it is scalable. In 3 of 10 studies, they reported the benefit for suicidal ideation. The Assess, Intervene, and Monitor for Suicide Prevention model was proposed as a framework for implementing the Zero Suicide model in clinical care. Assess refers to the use of systematic screening and comprehensive risk assessment to identify at-risk patients. Intervene consists of conducting suicide-specific brief and psychosocial interventions. Monitor provides strategies for ongoing monitoring and increased contact during known high-risk periods. So this provides guidelines for clinical training and best practice that can be applied in many different care settings. And these are the 10 steps in the Assess, Intervene, and Monitor for Suicide Prevention model. Mental health professionals lack the knowledge and skills needed to intervene with suicide. So the goal of the role play is to facilitate optimal skill development and usage on behalf of mental health professionals working with suicidal clients. So they use the question, persuade, refer, and treat risk assessment training. This incorporates active learning and behavioral modification strategies. It's first modeled to training participants by an experienced trainer. After observing, each participant then takes on a role of a clinician and role of the person at risk. During the role play, the skilled trainer provides feedback. This positively influenced mental health professionals' attitudes and perceived social norms towards engaging in suicide prevention strategies. It was also found to be helpful in developing and refining suicide risk assessment and management skills. Training medical providers. So they use the Suicide Prevention Toolkit and associated training curriculum. The curriculum provides instruction related to understanding the epidemiology, prevention, and intervention of suicide within each of these factors. So the 3 constituent factors are perceived burdensomeness, low belonging, and acquired ability to enact lethal self-injury. And this is based on the chronic care model. The chronic care model identifies 6 basic elements of a healthcare system that encourages high-quality chronic disease care. So the 6 basic elements are the community, health system, self-management support, delivery system design, decision support, and clinical information systems. The toolkit is also divided into 6 sections, which are getting started, educating clinicians and office staff, developing mental health partnerships, patient management tools, state resources, policy and billing, and the patient education tools and other resources. It was developed to provide instruction to individuals at any level of training. It makes it useful for providing medical students, residents, and providers with evidence-based education on the assessing and management of suicide risk. Now, in the youth, including therapy for both the parents, caregiver, and the youth. So including the parents may help them support their children more, and it also may help them learn skills their children are learning. This may increase communication as well. Therapeutic alliance between parent, caregiver, and the youth. So the connection they have with the parent and child is really important. They should have a trusting, supportive, and engaging relationship. Individual tailoring to guide treatment. So adjusting to the individual and specific factors will help structure individual therapy sessions and update safety plans. Skills training and safety planning may improve emotion regulation, distress tolerance, enhancing social interpersonal functioning, cognitive restructuring, and impulse control behavioral inhibition skills. Lethal means restriction counseling emerged as a common content element in supported trials for reducing suicide attempts. All of these are key clinical guidelines outlined by the National Institute for Health and Clinical Excellence. So the traditional workforce education methods, which include expert workshops, which are real-time trainer-led group instruction. This increases the knowledge, skills, and self-efficacy and can reduce provider anxiety in addressing suicide concerns. The Model School District Policy on Suicide Prevention provides guidance on the best practices to prevent, assess, and intervene when suicide concerns arise, includes a minimal level of annual training. The Guide to Developing and Revising Suicide Prevention Protocols for Youth in Contact with the Juvenile Justice System includes similar elements and recommends 8 hours initial suicide prevention training for all direct care staff and an annual refresher. Train the trainer approaches. This is when experts train second-generation trainers who go on to provide the workshops. This can be effective in improving outcomes of suicide. Independent online learning. This allows for an on-demand training that can be viewed anywhere and can ensure content fidelity and consistency. In adults, depression management education of doctors has been found to lower suicide rates. Assessing any predispositions to suicide and checking for specific factors that contribute to current suicidal thoughts. This includes a history of suicide attempts, history of abuse, time in the military, and previously diagnosed psychiatric disorders. So evaluating for any psychiatric illness is also important. Clinicians should also ask for a detailed narrative of an individual's suicidality. Getting information from family friends is also important for understanding what led up to their current state. So the greatest risk for completed suicide is in the elderly. Screening for psychiatric disorders is very important. 45 to 75% visited a physician within the last month before dying by suicide. Direct questioning about their life stressors and thoughts of death is also very important. The review of medical history may reveal additional information to enhance assessments of suicide risk. Depression, substance use disorders, and anxiety disorders were most prevalent. Elderly with depression may appear to be declining cognitively, which can appear as pseudodementia, which creates a decrease in ability to cope with stressful circumstances and increased impulsivity. Some medical conditions were found to increase the risk for suicide by 2 times more. Individuals' own perceived health status, which is having a bleak outlook on one's overall health, also increases the risk of suicide. So the majority of older adults who attempt or die by suicide suffer from depression, but can also occur in the absence of risk factors like depression. The prospect and impact studies are based on the collaborative model of care in which guidelines-based care is provided by physicians with the support of a nurse, social worker, or psychologist and depression care manager. So this involves a care manager, which serves as a connection between patients and physicians. The care manager monitors symptoms, side effects, and treatment adherence and communicates this information to the physician. This was shown to reducing depressive symptoms and the presence of suicidal ideation. The Senior Connection aims to prevent the development of suicidal ideation among at-risk older adults. This is grounded on the interpersonal theory of suicide, which proposes that social disconnectedness brings about the desire for suicide. An intervention for this involves companionship and supportive interpersonal interactions provided by an older adult peer. Sleep complaints such as insomnia and nightmare symptoms may be associated with a higher risk for suicidal ideation, suicide attempts, and death by suicide. These may serve as a modifiable empirical risk factor for suicidal behavior, which presents an opportunity for suicide prevention. It's listed as the top 10 warning signs of suicide by the Substance Abuse and Mental Health Service Administration. I thought this was really interesting because I would have never thought that sleep disturbances was related to suicide. Differences in gender. Men make fewer suicide attempts but use more lethal means such as hanging and firearms, but are 4 times more likely to complete suicide compared to women. So women attempt suicide at a higher rate, and they tend to rely on drug overdosing. So specifically, Caucasian males 85 years or older are a high risk group for suicide. This might be due to the fact that women are more likely to seek help. In conclusion, educating people such as general practitioners like nurses and doctors who see future suicide patients prior to suicide may lower suicide rates and result in less suicidal ideation and behavior. Educating the youth may also lower the suicide rates. Training medical providers allows them to be more educated on how to assess and manage suicide risk. This would also include the role-play practice, which increases the skills needed to intervene with suicide. Screening for suicide risk by using screening tools such as the P4, the Columbia Suicide Severity Rating Scale, and the Suicide Assessment 5-step evaluation and triage may help prevent suicidal behavior in individuals where it has been undetected, and this helps reduce suicidal behavior. Also, treatment such as psychotherapies like CBT and DBT help prevent suicide. This may look different in all ages, like the youth, adults, and the elderly. In the youth, it seemed to be more helpful when including the parents. The elderly were at the greatest risk for completing suicide, especially in men. So there was a gender difference. Men were more likely to complete suicide, and women were more likely to attempt it. And these are the evidence-based strategies in assessing suicide risk. The suicide rates are very high, making suicide the 10th leading cause of death in all ages. I don't really hear about suicide, but suicide is a very important topic and should be assessed and talked about a lot more than it is. So there is some gaps within this research. Although CBT is very effective, the implementation of it is lacking. And for DBT, there is insufficient evidence for the treatment in individuals who do not have bipolar personality disorder. Technology-based interventions, there's just little evidence of its effectiveness For the crisis response plans and safety planning, the quality of evidence remains low and also hasn't been studied enough, so there's insufficient research on this topic that uses large sample sizes. Lethal means safety intervention. This has also just not been studied enough in clinical settings. Thank you.